Hi, everybody. The big takeaways from Chapter 4 on anxiety disorders and obsessive compulsive disorders are these. First takeaway, number one, remember that continuum between normal and abnormal behavior. Think of it like a linear, a line continuum. Um, Abnormal and normal are on the same continuum of human experience. Psychological disorders are most often experiences of the perfectly normal thoughts, feelings, and perceptions taken to some extreme in intensity or in duration. For example, at some point, feeling anxious elevates into an anxiety disorder. It becomes more intense and it becomes longer in duration. It just doesn't go away. You're tense every day, over and over and over for weeks. At some point, feeling anxious becomes an anxiety disorder. Everyone experiences anxiety at one time or another. This is normal. Anxiety disorders are far greater in intensity and duration, like an extreme version that lasts for a long time. So remember that continuum between normal and abnormal. Takeaway number 2 here is the foundation of all of these very different types of anxiety disorders is the same, and that's fearful thoughts about what might happen in the future. Thoughts or cognitions are at the core of all of these very different seeming anxiety disorders. For example, in a phobia, the fear is what might happen if I encountered the feared object or event. In obsessive compulsive disorder, the fear is what might happen if I did not take action regarding some compelling thought. The fear in post-traumatic stress disorder, of course, is what might happen if the traumatic event occurred again to me. Fearful thoughts or cognitions are all at the core of all of these very different types of anxiety disorders. The next takeaway number 3, this chapter also demonstrates something that takes us back to chapter 3, actually. This chapter also demonstrates the overlap of disorders. Now, back in chapter 3, this was called comorbid diagnosis or comorbidity. Read carefully these descriptions of disorders, the symptoms that are in there, and you'll see that the groups of symptoms start to blend into each other. It's not blending, it's overlap. They overlap with each other. This exists because patients are complicated and their conditions change over time. It's possible to have comorbid diagnoses, two disorders at the same time. For example, a panic attack may turn into agoraphobia if a patient becomes so frightened of a repeated attack that she never leaves her home. Somebody with a phobia of germs, a germ phobia, can become so pervasive that the person becomes obsessed with germs to the point of an obsessive compulsive disorder. Comorbid diagnosis, two diagnoses at the same time. And subsequently, that person could even become housebound if they think the house is perfectly clean and all other places are not. What started out as a germ phobia becomes much more than that, more complex, over time with the same patient. So please revisit this concept of comorbidity from Chapter 3 on assessment. The co-occurrence of different disorders simultaneously. A person can have more than one. It's worth noting that one of the most common comorbid diagnoses, by the way, is an anxiety disorder alongside of a substance abuse disorder. We refer to this as a patient who is self-medicating. The person may be medicating themselves after discovering how alcohol and drugs can calm their nerves and relax their anxiety. So oftentimes they come see us with a substance abuse problem and an anxiety disorder, comorbid diagnoses. So finally, the last takeaway number 3 here, big takeaway number 3. Ideally, treatment of major psychological disorders, and we'll talk about this through all of the disorders in the rest of the semester. Ideally, treatment comes in 2 steps. Step 1 is drug therapy, medications. The patient will immediately be put on medications if it's appropriate. Step 2 will be talk therapy or psychotherapy. This medication first approach has several benefits. We really, as psychotherapists, we really cannot sit down and do talk therapy with a highly distressed patient with depression or anxiety. So the medications first calm the patient down and allow discussion and learning to take place in the psychotherapy sessions. Really, the patient must focus and concentrate in order to learn from psychotherapy, this reflection and self and insight into self. They have to be able to focus and concentrate, right? Medications will also help the patient get a better night's sleep and think more clearly, allowing greater problem-solving ability during the talk therapy. So medications come first, talk therapy comes later. As coping resources improve, as they're learned through psychotherapy, we will then eventually decrease the medication dosage until it's just no longer needed. So those are the three big takeaways. In summary, takeaway number one, remember the continuum between normal and abnormal. Psychological disorders are most often experiences of the perfectly normal thoughts, feelings, and perceptions taken to some extreme in intensity or duration. That is, at some point feeling anxious elevates into an anxiety disorder, for example. Number two, the foundation of all these different types of anxiety disorders is fearful thoughts about what might happen in the future. And lastly, number three, in this chapter, you'll see that the group of symptoms can blend into each other. The patients are complicated, and these can change over time, realistically. Also, ideally, treatment comes in two steps. Step one is drugs or medication first. Step two would be talk therapy or psychotherapy. Those are the big takeaways from Chapter 4 on anxiety disorders and obsessive compulsive disorders. Thank you.